It's 12:16. It seems our rate of addition has slowed a bit, so we can go ahead and get going. Hopefully the agenda is not too long today, but we'll see how things go. So everyone had a lovely weekend. Seems the world has calmed a bit for the moment. Although I will say Saturday, it seems that all the news outlets and whatnot have all kind of agreed that we are definitely coming down from the pinnacle of this most recent wave of the pandemic. But then there were 2 or 3 infectious disease experts that got quoted, and now it's kind of being picked up everywhere for folks who like to follow this stuff on Twitter or whatnot. Somebody actually said that we were facing a coming category 5 wave of the pandemic, which I feel like we just keep getting hit, and every one of them is a bigger category 5. So I don't know which category 5 is coming potentially, but it's the variance is what's raising a lot of concern for everyone, both because the spread is more frequent and the virulence and mortality risk seems to be higher, at least for a couple of them. The current rate is actually seemingly slower than what they had anticipated, but they're really anticipating that the variants could become the dominant spread by March into April now is what they're predicting. So I think that's what the fear is. And so as we've talked about multiple times, the goal is really to get ahead of it by getting the vaccine distributed as hearing the Biden administration talking about trying to accelerate vaccine production. And for weeks now, we've been saying, the vaccine can only be produced as the vaccine can be produced. There's really no way to jumpstart that. Certainly Johnson & Johnson could come on the market. That may help. But then Moderna on Saturday, I think it was, came out with a little bit of a surprise, which I had not heard before, where they have now petitioned the FDA to have 15 doses per vial rather than 10. So the current vials that they are distributing, supposedly they think they could get 15 doses into a vial rather than 10. Sometimes they get 11 in a vial. So the fill and finish process by which they generate the vaccine and actually get it into the vial is supposedly what the bottleneck is for the manufacturers. It's actually not the production of the vaccine. So they could actually release vaccine faster if they could get it into larger aliquots per vial. So we'll see where the FDA goes with that. Obviously, if they can get 50% more vaccine into a vial, I would not complain about that if they've got that vaccine laying around in a bucket in the store shelves to get that out. So I know nothing about what the significance of that is other than sounds like a good idea to me. So I don't know why the FDA would say no right now. So that could change things considerably if they could accelerate the distribution of vaccine that much faster by just cramming more doses into a vial. So that's number one. Number two, on Friday, the first wave of the information from the Johnson & Johnson vaccine really came out for popular review. Many of you have probably already seen it. The efficacy was about 66% in the foreign trials as far as protection against the virus. Two things about that. So immediately everyone says, well, that's not as good as Pfizer and Moderna, and that is true. However, a lot of the enrollment seems to have occurred in areas where the variants may have been more prevalent. The question is, were those variants as prevalent when the enrollment was actually going on in the trial, given that these trials have been enrolling for 9 months now? But number two, that it was 90 to 95% effective at preventing severe form of the disease. So in the case where people got it and were in that unfortunate 34% group that were not fully protected by the vaccine, they had a much more mild form. So I think this is going to be important as we go out, because clearly this vaccine is going to be in fairly large quantity and hit the market pretty quickly. Is it as great as Moderna and Pfizer? I don't know that we have enough data to compare head to head at this point, and certainly we don't have head-to-head trials. However, if we knew 95% chance that we could prevent hospitalization from the infection, that's still pretty damn good, and that's good enough from a standpoint of curbing the morbidity and mortality of this infection. So, I think it's going to be incumbent upon us, because patients are going to ask, they're going to see those numbers, they're going to want to refuse getting Johnson & Johnson if it does go to EUA within the next week or so, which is what keeps getting profited is going to happen. And if they have 100 million doses that hit the market, and all of a sudden people start getting the call and invite to the Johnson & Johnson clinic and turn it down because they want to wait for Pfizer and Moderna, even if they're cramming more doses of Moderna into vials, we're still not going to get 100 million more doses hitting the market that much faster. So, I think we'll learn more, obviously, as this data continues to trickle out. It probably is not perfect. One of the discussions all along is are we going to get into a situation where if you got Moderna and Pfizer, you should get a booster with Johnson & Johnson or AstraZeneca later, and vice versa? We're still a ways away from even that discussion as well. But I think from the, should grandpa who can't get Moderna and Pfizer, should he at least get Johnson & Johnson? As of today, I would say that's absolutely the case. Because if we can prevent that hospitalization, that's a hell of a big step in the process of this. Also on the backs of that, again, as we learn more about the disease, interesting tidbits come out. Of those who were hospitalized with COVID, approximately 15% have then been found to have diabetes, actually both type 1 and type 2 after COVID. So they were not diabetic pre-COVID, and then 15% of all hospitalized have diabetes after. So is that because they got whopping doses of dexamethasone in the hospital and they're now diabetic? Is that because this somehow has some kind of inflammatory effect on the islet cells in the pancreas? Obviously don't know, but it's an interesting tidbit that so many were diagnosed with diabetes so soon after the disease hit. So all kinds of this stuff that's going to be coming out as we learn more and more about the disease. But really the goal right now is get as many people vaccinated before the variants take hold in the US. It does appear that on almost all cases, the vaccines probably have pretty good efficacy against even the variants. There is some concern that the Johnson & Johnson may not have great efficacy against the South African variant, but that hasn't been well tested as of yet. So I'm sure we'll learn more about that as the EUA comes to fruition. But certainly, I think we're getting data a lot faster now as we're starting to get more study of the people who were infected, and as we're starting to see all these vaccines come to market. Colleen, I see your message in the chat as we're going. Guidelines for pregnant patients getting the vaccine. Is it safe? So absolutely is, and it's actually even been recommended because the risk of COVID in pregnancy is super not good for bad and adverse outcomes. So the recommendation from the American College of Gynecology, from our own chief of OBGYN at the U of R, have all been very strong that pregnant women should get vaccinated. Now, obviously, you should still have the conversation with your OBGYN, but there's very little reason why pregnant women should not consider getting it. The WHO statement that was released, I think we talked about this a little bit last week, has been misinterpreted in the popular press as saying that pregnant women should not get vaccinated. And that story's been run with. So we've been trying to share that education. I think ACOG has now come back out with a clarification to WHO statement. I have not seen any further follow-up from WHO, but the popular interpretation of the WHO statement that pregnant women should not get vaccinated probably is having some adverse consequence across the world, really, as to who's getting vaccinated, who's not amongst the pregnant population. So with that, as of Friday, there were just under 50 million doses of vaccine that had been distributed. We were just at 28 million that had been administered. So we were slightly over the halfway mark. We certainly see, it's interesting as you follow the states that are doing better or worse than others. It was that kind of southeastern Sun Belt that was not doing very well. Pretty much anywhere where anyone of the Teeters family may have come from, we're not good at giving vaccines. So I'll take it as one of the strong suits of my family yet again. But now it's moving up into the Northeast now that it seems that they're following me that we don't give vaccine very well in some northeastern states as well. So Wisconsin had fallen down on the list as far as vaccine efficiency in recent days. So Alabama still holds the record for the moment. So Sun Belt is still not doing well. So as we can see here, numbers wise, we are slowing as far as cases per day, which is good. We did have a little bit of a blip this weekend in Monroe County. Again, uncertain if that was catch up, what the case may be. I'm not aware of any large outbreaks as of late. But we did, I think it was Saturday, there was a rash of cases reported and then calmed down yesterday. But the positivity rate is now falling. Certainly locally, it's falling more precipitously. Fortunately, the mortality rate did not spike as much as, we kind of kept waiting with bated breath, expecting that we could see a surge in the mortality rate that followed the surge in cases. We haven't seen that as much at this point. I mean, certainly any mortality is too many, but it does appear overall that the mortality rate is decelerating from where it was even a week or so ago, which is good. So across the board, it pretty much from all takes, and our graphics show it as well. But even from the information that Nick Apostolero shares with us from the region, pretty much every county is seeing improvements. Look at that, right on cue. Wow. So all counties are really showing a decelerating course, which is great. And we're pretty much seeing that across the Finger Lakes and really across all of New York. So much so that almost all of the yellow, orange, red zone restrictions have been lifted. There were still a few areas in the downstate region that are still in place, but certainly west of Albany, I think there's no further yellow, orange, red restrictions in effect at this moment. And there's a push nationwide really to get schools restarted, hopefully, especially depending on what happens with this stimulus bill, to increase funding to schools so that they have adequate screening and protections in place to get kids back. With that, there has been a rash of lawsuits. I know as close as Buffalo, the teachers union lobbied a lawsuit at the end of last week, trying to prohibit return to full school because of concerns about risk of infection to the staff. So we're probably going to see some legal maneuvering here in the next week or so as the really all the states decide whether to reopen schools. And I think depending on what happens with this budgetary relief, the Biden administration is pushing for 1.9 trillion. The Republican group of 10 have now countered with 618 billion. They're meeting today to arm wrestle over that and see if they can come to any happy conclusion. The Democrats think they have enough through reconciliation to pass the 1.9 trillion stimulus if they so choose. A lot of what's cut out of the Republicans' proposal, as I understand it, is some of that money that would go to states. So if there is any kind of agreement, I can imagine some of these lawsuits that some of the teachers unions and school staff have been lobbying may have greater merit. But if the federal government comes out with significant funding and resource allocation to school systems, I suspect we're going to see less and less reason that they're not going to be pushed to reopen schools fairly quickly. There was something interesting. LJ may have it better than I do. It's something for every month that the kids are out of school, their lifetime earning potential goes down by something like $1 an hour or something like that. It was a really large amount. It was really significant. So obviously there's going to be that push. And if the financial resources and the PPE and all that's going to be there, I think it's going to be harder and harder to argue that we shouldn't get kids back to school sooner, especially as we're seeing that schools are really not the zones of transmission for the virus. With that actually segues into another point that's come up in several emails. In fact, we got another one today asking about with the variants, what should we be doing in practices? What should the guidance be within our practices for staff, both with encounters with the lay population, but certainly with folks who are coming in with respiratory or really any symptoms, knowing that GI symptoms can be on the radar for COVID. So best data I've seen to date, and again, I fell on the grenade last week after Fauci tried to shoot me down. He was just doing it to mess with me personally. I took it as a personal offense. So as soon as we said that the data had suggested that there was no clear benefit to double masking, Fauci came out and said, Chad lied, there is, and he was right. So I would say it's probably hard to argue if you're just going to wear a surgical mask that you shouldn't double mask. So the best data I've seen so far says that double masking, as long as the two masks are made of different weaves, so different types of material or construction, that you get to about a 75% efficacy. If you triple mask, just because you're trying to show off, you get to a 90% efficacy at that point. Now, people have started asking, well, I've got a mask that has this insert, it has this thing, there's this layer. Now you're out of my wheelhouse. So I would say, I don't know the construction of every mask. So I would say if you have a surgical mask and a cloth mask, I'm going to call that double masking. Triple mask, any other weave that's not what the primary cloth mask is. If you have a mask that's 2 layers, maybe that means you've quadruple masked. I don't really know. But I would say if you've got a mask that has 2 different types of cloth in it, that probably is a built-in double mask is my guess. There's some people that have mentioned that there are masks that have a kind of like a HEPA filter insert or some kind of filtration thing that goes inside the cloth mask. That sounds really cool. I looked it up this weekend just to figure out what the heck that was. The only one I saw, you had to change the insert every 130 hours, which, holy crap, that means like once a week you're gonna be changing these inserts. I can only imagine how fun that'll be. But long story short, single or double masking, probably 75% barrier protection. Triple masking, 90%. And N95 is 95%. So as to the questions that folks raised, we are getting more and more supply of N95 masks. My understanding is even many of you in your own practice, the N95s are able to be purchased much easier. Under the best of pricing, we're still seeing N95s that's somewhere between 60 cents to $1 a mask. Many that you're buying, if you're buying it through less than reputable sources, it can still be upwards of $2 to $3 a mask. So that's a pretty expensive proposal to have everybody wearing N95s at all time. And let's face it, they're not the most comfortable and breathable for most people. So, as to the question with the variant, hopefully almost everybody on this call is now vaccinated. So you've got the biggest protection. I would say double masking with a cloth mask and a surgical mask should be pretty doggone sufficient. But if you're going into a room with a person under investigation or suspected respiratory or possible COVID, I would say you want to be wearing an N95 mask. I think that would be smart. So especially if you're going to be swabbing somebody, and I would still say trying to minimize contact so that we don't have 10 people going in that room is all the better. So take the best protection you can if you're going to be encountering somebody who's potentially infected. So hopefully that answers that question. I realize that's not a perfect answer. For day to day, I was wearing a single mask. I have taken to double masking, if that means anything, just because once Fauci says it, I then have to subscribe to it like it's the word of God. So there you go. And because he made such a big deal of trying to prove me wrong on national television. So I took it as a personal offense and then the thing I do all day long. So there you go. And follow up to the Biden administration executive order about masking on trains, interstate travel. So not only did the executive order say you have to do it, there are actually some pretty hefty fines and risk of jail time if you don't. So I know several folks have mentioned that patients are still going to refuse. I would make sure people know they refuse at their peril. So it is not something that's going to be taken lightly. The CDC did come out with guidelines. I think the double masking is now a recommendation, especially for confined travel kind of situations. So not only is that now recommended, but it will be under threat of penalty if they do not. So take that for what it's worth as well. The final thing, and I believe Renee had mentioned this last week, there has been, everyone knows we're under threat of this nor'easter and snowstorm, that there's concern that that could hamper or impair both access or even ability to conduct the vaccine clinics. As of right now, they're planning on running these clinics come hell or high water. But I can imagine, especially we're talking about a 65 and older population, that their ability to get to the clinic could be impaired if travel is a bit treacherous. So Renee had sent out recommendations and guidance to all the practices about if patients could not get to a clinic that they were scheduled for, that they needed to cancel their appointment, just so we didn't have a glut of no-shows and a bunch of thawed vaccine, of how they could reach out and do that call. So hopefully that will not come to pass, but that is potential. Everyone probably heard on, I think it was Friday night, I think it was in Seattle, freezer went down, and so they had 800 doses of vaccine that were going to potentially go bad. So in the middle of the night, they actually sent out an all alert message to medical staff across the community and wound up not wasting a single vaccine. They got it all administered in the wee small hours of the morning because it all thawed. So that's great, but we don't want to necessarily be trying to do that in a snowstorm. So make sure folks know that. The final piece, we alluded to this in our PCP advisory meeting last week, but we have some good news in that one of the things as we kind of learned from this allocation and group access for purchasing for supplies was that the individual purchasing power of all of our individual practices is not what we would hope. And whether it's a pandemic or otherwise, not only is our allocation access not great, but our price competitiveness is relatively poor. So we have been working through Vizient, which is one of the large national group purchasing organizations that the U of R has partnership with, and then also with Medline and Provista, which are two of the distributors and suppliers, to try to set up a group purchasing arrangement for AHP and all of our member practices. After multiple months, and this is really thanks to Renee and Kim Povic and Mark Cronin from AHP, who have really been doing the offline work with all those teams. We now have an executed contract with AHP on behalf of Vizient and Medline for all of our practices. So what does this mean for all of you? So at no cost to any of you, you can enroll in this program, which will get you access and pricing that is commensurate with what the U of R pays. When we looked at some of our larger practices, the savings was on par with about 25, 28% over what pre-pandemic pricing was. So the anticipation is that the savings could be quite substantial for all of you, both on PPE, but also all of the purchasing for syringes, Band-Aids, table paper, you name it. The other thing, there's also even some group purchasing discounts for things like telecommunications, cellular contracts, computer purchasing. So it's pretty far reaching. So the benefit is just by being an AHP member, you gain access to this program. We'll have a lot more information to share with you soon about this, but basically you just sign up and then they have reps who are happy to meet with you or your team to talk about. For most cases, you're talking an exact transition. So you ordered Medline or 3M Band-Aid number 7, you can get it. It just comes from a different distributor. There are some cases where it's not the 3M Band-Aid, it's the XYZ Band-Aid, but it looks and performs exactly the same. It's just in an orange box, not a green box. So they can show you both and show you what the cost benefits and opportunities are. The other thing that they promised is they want to make this as painless as possible. So they will take your list of items that you order routinely, especially if you have an old receipt of orders that you've placed over the course of the last months or whatever you order routinely, and then they can program it into the system so that there's really no work on your team's part to have to reorder or re-enter all that. So more to come, but that's going to be an opportunity, and certainly Renee can speak to that further, or if you have questions, certainly reach out to us. With that, and with allocation now becoming less of an issue, As much as we have enjoyed the PPE business and as much as my car has doubled as a U-Haul to and from the loading dock, it is probably time to sunset those efforts now that we're a year into it. So we have gone out and we have pre-purchased what would be the equivalent of about 2 to 3 months of supply that we've been distributing thus far. So most of that is sitting on the loading dock as we speak. And I'm going to be doing a lot of shuttling to and from this week, and we're going to pack the office as much as we can. So here in the next probably couple of distributions, you're going to be getting a lot larger supply of stuff than you probably have before. And the goal of that is really to both bridge through the end of this pandemic phase to make sure that you have more than adequate quantity of everything you would need. That includes even things like nitrile gloves and all that are in short supply everywhere right now. So we've pre-purchased all that. So we will be distributing that out. The other goal is that will be enough of a bridge to hopefully get you to the point where you can fall to the new contract if you so choose to pursue that. So hopefully that will be enough of a goods and services to get you through that window of time. It sounds like they think that they could probably have most folks up and operational within 30 days with this new contract. So more to come on that, but we'll keep talking, but I expect the next distribution, which will be a week from Wednesday, to be a little bit more presence in the stocking than what you have received to date as we start pushing this large quantity of goods out. All right, with that, I'm going to shut up. I know Renee or LJ has some update on the return to play, which we all know and love.
Well, yeah, I know you were waiting for more updates on that one. Actually, I have a good update. A team from Rochester and Buffalo, primary care providers and pediatric cardiologists, met with leadership at the American Academy of Pediatrics on Friday. And so we are making revisions to the guidance. The AHP has not come out with any modifications yet to their interim guidance statement. But in hearing about the situation that we've been faced with, where it's essentially impossible to do an observed return to play for younger children or for children who are not in sports, and really kind of pushing them a bit on where that guidance is coming from and what the evidence is for that piece, we are at least, we were definitely instructed that we should be modifying our guidance appropriate to our experience in our region and our local experts. So from a primary care provider standpoint, this does not really change very much, because at this point, the AHP is not changing the recommendation that children 5 and up should at least have that assessment once a child with COVID-19 is released from isolation. So if you think about the algorithm that we used before, your role doesn't really change. Those children still should get that assessment, both in terms of assessing whether their COVID experience was mild, moderate, or severe, and then assessing if they have any cardiology or cardiac symptoms or significant cardiac history that puts them at risk. However, what will change is as you work your way down the algorithm, if you have seen a child and have cleared them from your perspective to begin return to play, for children under the age of 12 and for children over the age of 12 who are not engaged in competitive or intense physical activity, those kids can go back to immediate play, full release to play. There's no need to provide parents with a listing of things that they need to do with that child. There's no reason for the schools to have to do a PE guided return to play. So what I like about this is it gets us back to focusing on the 12 and up group and the kids who are in competitive or intense physical activities, your competitive runners or your kids who are involved, maybe not in school sports, but in other really intense sports. So bowling does not apply unless somebody is a really crazy bowler, where they're doing flips down the bowling alley and then, throwing the ball. So we are revising all the guidance again. It doesn't look a whole lot different. We should be able to release this in an email. We're going to send a separate email, not in the guidance that comes out from AHP on Mondays and Wednesdays, thanks to Renee and team. This will be a separate email that will have everything revised, and we'll be notifying our school partners about this. My hope is this will allow us to work better together again, because I think that the trainers and the coaches will be more willing to look at these kids over a 7-day period for their athletes and just watch them. So it feels like we're moving towards more common sense. And even if it's not completely evidence-based, the AAP also was, the vice presidents of the AAP that we met with were very interested now in hearing more, not only from our hospital systems, but from our colleagues in Boston, and others who are collecting this data and looking at this to see just what the evidence really says about risk for younger kids. So more to come on that, but those things are changing. So for all those of you who sent me emails on Friday or Saturday or Sunday worried about this guidance, I will send you an email today now that we've got assurance that this is changing. I'll just confirm for each of you who had been pulling your hair out over how this is not working well. And the last thing I just want to say is I noticed in the chat, for those of you who are watching the chat, that Genesis Peds had noted that they've encountered an urgent care that's telling parents not to get their symptomatic and their asymptomatic kids tested, just assuming that they're positive and quarantining them. That's not exactly the guidance that we've had. If a child is symptomatic, they should definitely be tested. And so if Genesis Peds can give us a little more detail privately on that, we will follow up with the urgent care to make sure that they have the right algorithm for what should happen. We do know, again, you all will remember that the health department is recommending that close household contacts of a positive case do get tested, even if asymptomatic, around 7 days. The hope for that is really to catch some asymptomatic positives so we don't release them out into the community to spread further. It's not a requirement, but that's what that recommendation was for. And then the Genesis Peds also put in that message. I just wanted to clarify. If you are in a household where there are very young children who can't be masked and everybody is kind of with each other and you cannot separate, then that promotes a very long quarantine period, and it just is what it is. So those kids need to be quarantined with their sick parent or a family member right from the beginning. And then that 10 days of quarantine again starts once the parent is released from isolation, once the parent is considered non-infectious. So it's a long, long time. So you're right, Genesis. That's it for me.
Perfect. Renee, do you have anything to add?
Nothing.
Okay. It actually occurred to me as I was talking about the Vizient midline relationship as well, that two things. So one, if there should ever come a time where the world allocation comes to a screeching halt again, we still maintain our relationship with the U of R supply chain folks. So as they source from other vendors, we could always go back to utilizing that benefit if we needed to. So that doesn't die. Number two, one of the benefits for the way we constructed this large purchase that we did was not just that we would have a bridge to affect this GPO operation, but also because it gives us an avenue to where it allows us to have preferential access through that supplier as well. So basically, we're keeping multiple irons in the fire just in case. We anticipate that the allocation shouldn't be a problem going forward. But if there ever should come a time, we've got all the avenues that we are currently making use of and more, quite honestly, with this new arrangement that we'll have in place. So I just want to make sure folks knew that this wasn't going to be putting us into a situation where we could potentially get back to where we were last March. We should be in pretty good space going forward. All right. With that, I think we have run the list of the chat room. Any questions that folks have? Seeing none, hearing none. We will call it a day. Everybody gets 10 minutes of their life back. So we'll see you back on Wednesday. Have a lovely 48 hours, and we'll see you all soon. Take care, everybody.